Marie, I would love, you have such a rich history in really helping to define the nursing profession. I would love for the people in attendance tonight and the people who will watch this video in the future to hear about your work in innovation and background in nursing.
Okay, thanks, Oriana. I'm delighted to be here and talking about one of my favorite topics, which is nursing. And many of you know, I am of a considerable age, not to be mentioned, but I want to talk about it just in the context of what happens when you do achieve a considerable age and have an opportunity yet to look backwards and begin to understand in a different light what all was happening at a time when the innovation and experiences were going forward. So for me, primary nursing was the outcome of some innovations we were trying within a very strict structure of the University of Minnesota hospitals. The project was about improving the delivery of departmental services to the nursing units so the nurses could be freed of non-nursing tasks. Doesn't that sound familiar? That was 1968, 69 in through there. And it was a big project and had a lot of attention from the hospital and the university because we had university professors that we invited to be on a university-wide committee. So there was a lot of attention being paid to it. And almost towards the end of it, we ran into a big roadblock with the nursing staff. They decided that they were tired of the project. They were tired of all the data collection. They were tired of being as specimens. And they rebelled by threatening to quit the whole unit all at once. So the supervisor and I weren't sure what to do. And we had a night meeting at my house. And we sat around and we drank beer and wine. And we talked about the problems on the unit. And that night they asked me and the supervisor if they could change the way they were assigning, patients were being assigned. And if they could have something to say about how the patients on the unit right now would be better cared for by changing the assignment. And she and I looked at each other and we swallowed very hard because we knew that we were stepping out of a boundary. And we said, yes, it's okay. We didn't understand, I didn't have any idea just how far out of a boundary we were stepping because all we thought we were doing was changing assignments. So part of my lesson here is that change can evolve in ways that are unplanned and yet be very effective. This was organic change. I didn't understand it at the time. I didn't understand anything about what was really happening in the deepest sense at the time. But as the experiment evolved, they began to develop the role of the primary nurse. I think it's really important to understand that this was not designed in anybody's office. It was not the product of a research grant. It was not a curriculum change of any kind at all. It was practicing nurses were inappropriately ratioed and inadequately staffed for the acuity of the patients. In other words, a perfectly normal operating situation. And it was within that situation that the nurses evolved, developed, created the care delivery system of primary nursing and the RN role of professional practice. The evolution of that moved, and I think this is one key point, I think, for innovators who are doing something that's working well and want to see it spread, want to see it evolve. I knew that what we were doing could not be explained just in the context of the 23-bed medical unit at the University of Minnesota Hospital, that we needed to be able to describe this change in language that was generic enough that it could be applied in any situation. That's what the next couple of years allowed us to do, and also to learn about the importance of changing the entire administrative structure of nursing to allow for the empowerment of the bedside staff nurse. That required a very big adjustment in people's roles, people's understandings of their responsibilities, and in the whole concept of unit leadership when we moved from the head nurse to the nurse manager. Major change in concept, which eventually required the development of a leadership program development, which we still have called LEO. So the evolutionary change occurred in practice first. And there were certain external constraints that were somewhat threatening, but there was enough support for what we were doing that the external constraints, like my director of nursing who couldn't understand what we were doing, like some of the supervisors who thought we were insane. So there were those, and the faculty who absolutely could not grasp what we were doing. So those external constraints all existed, but we kept on doing just what made sense. And we kept on letting it grow and evolve. I could spend a little time telling you about how it grew from one seminar in 1970, 2 articles in an obscure nursing journal in 1971, a 3rd article in the American Journal of Nursing in 1973 about the role of the nurse manager. And from those 3 articles and the seminar and the work that we were doing, going out and explaining it to people, by the mid-'80s, it was really the care delivery system of choice. Now, I've watched it grow and thrive and get smaller again. As Julie and I were talking earlier about the impact leadership attitudes have on practice, I have watched how administrators who are threatened with having too strong of a nursing department have found ways to discourage the further development of primary nursing. So we are somewhat, I don't want to say victimized, we're somewhat, there are circumstances that sometimes have an impact on how far we can go. But the thing I've learned after all these years about primary nursing is it'll never go away. It is the role of the registered nurse and the patient, no matter what the setting is. In COVID, I know that we've moved away from the continuity of primary nursing, totally understandable. But at some point in time and in some settings, the opportunity for continuity and full responsibility for decision-making about the care of the patient will return, will reinstate it, because when people start looking at how to improve nursing practice, they see primary nursing and say, let's do that again. So primary nursing has grown from 1 unit, Station 32, University of Minnesota Hospitals, to literally a worldwide movement. I had the privilege of talking to a patient in the Catholic hospital in Rome, Italy. That's the hospital where the Pope gets his care. And she had a primary nurse, and she insisted that she has a chance to talk to the founder of primary nursing. Saw her about 18 months ago. She's dying of cancer, and she wanted me to know how her experience in the hospital had benefited so much by the primary nurse. The book I wrote has been translated into 5 different languages, and it continues to grow and thrive. So primary nursing grew by accident from a meeting in my living room. It was never sanctioned, it was never supported, it was never defined as the model that the profession should use. It has always been an organic process. And I, at this point in my life, looking back on everything, sees that I really feel that this organic idea is something that we need to grasp the value of, like right now, and begin to think about how can we make changes that are completely within our control, even though people may not see it that way. So I'm just going to do a quick introduction of one of my other initiatives, the Nursing Peer Support Network. You may or may not know that I am a recovering alcoholic, that in 1978, I was fired from my job at Yale New Haven Hospital while I was in treatment for alcoholism. It was a complete right turn of my career. I thought I had lost it, and I have been in solid recovery ever since then. And until recently, I didn't know what we were doing to nurses who have an addiction problem. So the development of the Nursing Peer Support Network is a unique entity we've developed here in Minnesota that allows nurses to talk to nurses so that they can help each other overcome the stigma and shame, which we as a profession impose on nurses who are suffering from the chronic disease of addiction. This is a chronic disease, it's not a moral failure. I am personally very much involved in trying to figure out ways to help us dispel the myth that we hold that this is a moral failure rather than a chronic disease. And that's what opens the door to the conspiracy of silence, stigma, and shame. So the Nursing Peer Support Network is something else that has evolved from a need, people coming together, figuring things out. It's so important when you're making these kinds of changes that you think through what's the right thing to do. What are the principles here? What are the values? What should this be like? And then to take the steps involved in creating it. So we've become a model now. People are asking us throughout the United States to help them create a peer support network like this. And the third initiative I want to talk about quickly, because I really want to get our discussion going, are the salons. So 20 years ago, or maybe more than that now, I retired officially, resigned from being CEO of the company that I had founded, and thought to myself, well, now what, Marie? Now what are you going to do that you never had time to do before? First thing that popped into my mind was, I'm going to sit down, I'm going to have sit-down dinners. I'm going to cook meals, and I'm going to have friends come over, and I'm going to have them sit at the table, and I'm going to serve the dinner I've cooked. Because what with recovery, what with my career, what with raising 2 children single-handedly, I had pizza parties, or I had potlucks, but I didn't have sit-down dinners. So the first one was in 2000, and I had 6 people over for dinner. I know what I made. I know what I cooked. I know everything about it. I'll never forget it. And at that dinner, we had a wonderful conversation about nursing. In fact, it was so much fun, we hated to end it. And so we decided to do it again. And I told those 4 people, 6 people total, I said, invite your friends. And so it began. And so we started having these conversations in my home using something called the Socrates Cafe format, which is very simple. It's just have a check-in, have everybody answer a question, check-in question. What's on your mind about nursing tonight? And that becomes the agenda for the conversation. There's an emphasis here on conversation, not a discussion. It's not a problem-solving event. There's no agenda, no minutes, no after steps, steps required. We come together, talk about what's on our mind, and that becomes the agenda that we have a conversation about, sharing our thoughts with each other. That's the key to the healing that occurs. Margaret Wheatley, in her wisdom, said, conversations change people and people change the world. And I don't know about the whole world, but I know we are changing people and helping healing take place through the use of salons. They've grown all over. People can start them at any time. I will help anybody start one. I have directions and guidelines about how to start them and how to stay out of trouble with them. And they're going on in other countries as well. And so this, again, is an organic change. Started in Minneapolis, started when I had the first one. I actually named it Nursing Salons after a good friend of mine said, oh, Marie, don't call it conversations, call it a salon. That's what it is. It's a conversation by intelligent people on important topics. And so that's why we use the word salon. And I am just delighted to tell you that I have 2 a month that I host here, but I also do them. Last night I did one for the DNPs at the U of M, the new DNPs and HIL. So it was a wonderful experience. And salons, I think, are here to stay. They have a beneficial effect on people. And again, I have information about them on my website, which is www.mariemanthe.com. There's also a link there to get into the salon on Zoom, which I have the 3rd Wednesday of the month. And on the 4th Thursday of the month, I have one here in my home with a meal that they sit down and we share as we're doing the check-in. So these, again, are organic changes that come from within the profession and may or may not be sanctioned by the powers that be. And one of the important things about salons is that they should not be sanctioned by the organizations. They should not be sponsored. They should not take place within organizational walls. And there should be no financial support from the organization for them. So those are ways that we keep the salon in a safe place where people can feel safe to talk about their truth. So those are 3 examples of innovative changes that I've been involved in. And I don't know why I work so much sort of off grid, but at some point in time, everything that has a lasting power has to be put in the grid. And I've spent years developing the superstructure support that's required within the organizations to support this kind of development within practice. So Oriana, I think I should stop and take a breath now.
Yeah, absolutely, Marie. There's some great comments in the chat, a couple of shout outs, a shout out from Rhonda Anderson, who worked with you.
I know, I saw her. It was so neat.
Yep. And so, and a couple of other thoughts, again, people also having comments around nurses needing a seat at the table right now.
Yeah.
With that, how do we, as we're leading this work, nurses are having conversations around what the future of healthcare can be. Also talking about the role of interprofessional teamwork. How can nurses lead it? How can nurses be a part of those conversations, recognizing that change happens, across those teams, and how will nurses work into those teams moving forward. Also some comments around just being very, really drilling into just the staffing shortages and how that's affecting care delivery at present as well. So those are some of the other pieces. And Debbie, thank you so much for dropping those links into the chat. We want to make sure in our innovation work, we want to make sure that as we're moving this work forward, this is about building a bigger innovation community, about how we support nurses. How do we hold up nurses who are leading significant change already, so that we can build momentum and scale this work faster. So thank you so much, and love seeing all of these links. So Marie, we're going to keep dropping those links into the chat, and we'll do the same thing for Julie. So Julie, you are next up, and when we think about the conversations that everybody is having, that we're having tonight, and the pioneering path of nurses, our legacy and our future. Where are we going? How are nurses going to lead this work? And nurses have this rich history of not asking for permission, of seeing a need and stepping into it and leading new work for the country and the people that they're caring for in the communities. Where your work, you're doing a lot of work around culture, around empowerment, non-traditional roles. We would love to hear, have the group tonight hear about the work that you're leading.
Hi, everybody. And Marie, you always, inspire me, and I'm grateful for you. And for those of you who didn't know, at my dissertation project, Marie Manthe was there, and it was probably one of the most stressful and beloved times of my life. So, Marie, I'm just sending you a lot of love, and you're brave. You are brave. And then I just want to send a lot of love and gratitude and healing to all the nurses on this forum, and all the nurses who've been part of this history, this historic time. We're awesome. We played tons of different roles, but each one of us has given everything we had. So lots of love and gratitude sending way to everyone. So I have a non-traditional role. And one of the things that I think is interesting is that I really believe that nursing, by the virtue of how we think and the training that we have to be holistic in nature, that we see things as pieces of a whole, not a silo or a vertical, which really can jam up an organization, especially during a pandemic when people are supposed to be working together. So I oversee interesting places in the organization, but I want nursing to think about those roles. Innovation doesn't have to just be a topic. You can innovate by leading different areas in the organization. I think we need nurses' brains everywhere. EVS and food service reports up to me, as does system-wide marketing and communication. You want to put a nurse in a powerful role, put her in charge of food, which, food is medicine, or put her in charge of all of the communication strategies for the whole entire system, so that we can talk about love and we can talk about gratitude, and we can position nursing to be who they need to be in an organization, leading at the point of the patient, right? At the point of the relationship. So I think part of innovation for us going forward is for nursing to step into different leadership roles, different ways that they can have a seat at the table. We don't just have to lead nursing. We can lead anywhere we're put, because our brains are what, our innovative brains are what healthcare needs right now. Nurses are the most innovative people. Ask any nurse what they've done with a glove and a mortar and pestle, and they've probably solved 20 problems. Nurses are innovative by their nature. So step up to the plate, accept those non-nursing, non-traditional roles, and infiltrate the organization. We need your brain. And so I think that's one way that I have a very non-traditional role. The other non-traditional support that I have for the organization is I oversee strategic team engagement, patient experience, and well-being. And again, what a great place to put a nurse's brain on things that need a holistic view. And really interesting is that my doctoral project, which was really, built at University of Minnesota, Marie, off of relationship-based care, right, is culture disruption and how relationships matter. And if nurses are driving that relationships matter, that means that organizations have to put time and effort and money into them. And so being able to strategically disrupt organizations at the highest level, where they spend their money, how they view caring for their team members, I think is another great innovation that I think served us well at Vidant. Shout out to my Vidant team that's here, great nursing team. And when I think about culture disruption work and working on my doctorate and thinking, can this be operationalized? Can you operationalize a culture of love and caring by focusing on the healthiness of the relationships? And when the relationships aren't healthy, when they're too fear-based, Marie and I were talking about this earlier, leaders who are too fear-based and not as brave and confident as they need to be to drive nursing. When you're looking at how relationships are structured and you're thinking about how do you pull levers so that the relationships are healthier, the team members do better, and the patients do significantly better. And that is a path to nurse innovation. And, I think about nurse empowerment, and I just love listening to Maria. I could listen to her all day, because nurses know how to solve nursing problems. We just the leaders just have to, all leaders have to let us do it. And when we do it, and it is organic, and we've solved problems for ourselves and for our profession and for others, or for the other interprofessional groups, that's when changes really can shift, because nursing isn't waiting for someone else to solve a problem for them, and they're not accepting solutions that are outside of how we think, that holistic way that we were taught to look at things. You look at a patient, or you can look at an organization. As the chief experience and brand officer, I still am a nurse, and I still think like a nurse, and I still solve problems like a nurse, and I still see the world as a whole. The whole organization is just a patient to me. So I've been really fortunate to have a non-traditional role, and then again, really fortunate to be able to apply what I learned from relationship-based care, cultural transformation theory, shout out to Dr. Potter, who was a great mentor for me, and to apply that and operationalize it at the organizational level. And once you can operationalize love and empathy, there's nursing, that's what we do. And then organizations can take care of their nurses so that the nurses can take care of the patients.
So, I mean, Julie, so many of the things that you're saying are resonating with the people in the conversation, and talking about, within organizations, how do we help increase the chances for connection across an organization? People feeling like current structures actually minimize that ability for nurses to connect and the power in that.
So, Ori, are you asking about how do you keep your connections going within nursing when we're getting so siloed?
So just reading through the chats here, some of the attendees are talking about just the complexity of work, the amount of charting, some of those things,
Yeah.
and how that actually minimizes the ability.
Yeah. Well, this is a big worry for me, and I bet Marie has the same worry. Is that the way that we where we're headed is that nursing is so busy, and then of course let's put on the top of that we're full of grief, we've had loss, we're burned out. Then we stop communicating actively, having our salons, having discussions, solving problems, and innovating. And that is a worry for me because that's real right now. And then how do we keep ourselves well enough and whole enough so that we can push through this to make those changes? Because the way that those connections and so much busy work, if we can't innovate through that right now, never waste a crisis. As people aren't paying attention and as we're in a nursing shortage and a crisis, what levers can we pull to say, okay, enough's enough, we want this different, so we can get back to being able to collaborate together. It is a worry for me. Marie, I mean, doesn't that give you pause? Because you even said your salons are where we make things happen. What if we're so busy and burned out we can't even get there?
It is a worry, and I think part of the solution is for us to. I don't like to use the word self-care. I'm so tired of it, but
I agree.
There are some things we can do that will have an impact on the way we're experiencing our time. One of them is remembering. This is hard to say, and people are going to get aggravated, but then there always is more work to do than time available. In nursing, that's true always. There's always more work to do than time available. That means we always have that pressure to prioritize, to be making judgments. We need to learn how to honor the integrity of our judgments, to know that we've done the best that we can, even if everybody else doesn't agree with us, and to have the capacity of internal strength to be able to manage our self-talk so that other people's judgment of us does not become our judgment of ourselves. Yeah. There's one more quick point I want to make about self-care and about time and the perception of time. And it has to do with mindfulness is the correct word. I more often use the word presence. So I learned quite a few years ago, that the perception of time is all in our mind. In other words, time speeds up and time slows down according to what's going on in our head. Time is always exactly the same. And so there's an inexorable, absolute sameness about how many minutes in an hour, etc. But you and I know we've had days when it seems like the day just flashed by, and there's other times when we're sitting waiting for something to happen and time is dragging. Well, some friends and I were thinking about this and working on this idea. We began to notice that when we are present, that time slows down. So one of the things I've done with some of the nurses I've been working with is having them be intentionally present when they walk into the patient's room. Intentional presence has the effect of slowing down time. And it's something that we can use. It'll have an effect on the patient's perception of our availability, but also in our relationships with each other. When we stop and don't be thinking about what just happened and don't be thinking about what has to happen next, but just be present in the moment to the person you're interacting with, it has the effect of a sense of having more time. So it's not about playing games. It's about learning how to manage our own responses to things in ways that can have a positive effect. So those of you who are interacting with staff nurses, I suggest you just ask them to practice intentional presence when they walk into the patient's room, not thinking about what they're going to do, not thinking about what just happened in the corridor, but being present to the patient to see what effect it has on their sense of time.
Not only does it have an effect on their sense of time, but it also helps with burnout.
Yep.
Because when you don't feel like you're present and you feel like you didn't connect with your patient or your team member,
Right.
then you go home and say, I didn't do anything today, when you know you made the hugest difference with the patients, but you didn't get the enjoyment of feeling it.
Right.
And I know that that's really hard for people to do when we're really busy right now, but for themselves. And what I also want to say is not only do it for yourself, but do it for to guard your compassion and empathy, because if we lose those, we can't innovate, because innovation is empathy for the end user. We always do things, we always innovate. Marie, why did you innovate? You innovate because you felt something. You're like, this has got to change. But when we lose that, when we're burned out, then we lose our potential to innovation. And that's a really strange connection, because we're not really good at taking care of ourselves and each other. But if you really want to be an innovator, you got to protect that. You really do.
And you know, Julie, I think that's part of what this experience of COVID and the other catastrophes that we're dealing with in the world today is an opportunity for us to use, to become more intentional, become more self-aware, to become more willing to accept responsibility for our own thoughts, feelings, and actions, which is the first part of the responsibility paradigm. When we accept responsibility for the way we think, the way we feel, and the way we act, and experience the consciousness of choice about that, we give ourselves power to exercise our full capacity as holistic human beings. So practicing those principles now in our everyday life, I think, is part of what this horrific situation in the world is giving us an opportunity to evolve.
You know, I want to share with you one of the things that we started doing is we wanted our leaders to give people kind of permission to have presence and be mindful. So we started a kind of a Monday mindful meditation, but we had our highest level executives do it first. And it wasn't just nursing, it was everyone. So the CEO would do his mindful meditation. The next day, I do mindful meditation. The next week. And through that, we wanted to help people give permission. I think piece of this that we can do for each other, Marie, is to give each other permission to do this and not say, if that's kind of crazy, you're being kind of woo right now. I think we can say, you know what, that's for you. And if we role model it, and it becomes part of what we do in nursing, I think that will help our younger nurses see that that's okay.
You know, one of my concerns, Julie, is that we hold nurse managers accountable for so many things that have to do with the hospital operation, the regulations, finance, all these other things. But we don't really have a clear way of holding the manager responsible for advancing clinical practice, for making sure it's counted. So I would love it if the managers would start interacting with the nurse in the corridor saying, were you able to manage being present with John Doe this morning? How was that like?
That's beautiful.
You know, to start building those conversations. One time when I was chief nurse in St. Paul, Esther Lucille Brown came to my hospital. A lot of you don't know who that is, but she's a famous anthropologist who really did enormous contributions to the professionalism of nursing. And I was running around as a director of nursing, asking the staff, how's staffing tonight? How many admissions are you getting? Do we have enough help for you? Well, gee, I'm so sorry, we're so short staffed tonight. You know, and I'd say something really dumb like, if you have any questions, I'll be in my office. You know, as if I could say something intelligent about clinical work at that time. Anyway, then I made rounds with Esther Lucille Brown. And she walked up to the nurse and said, tell me, my dear, what are you doing this evening that's of interest to you professionally? I was like, pow. I mean, it was it just changed the nurses' presence and awareness. So I think there's so much more that we could do if we could ever, I was going to say, get rid of some of the work we're doing that isn't about clinical practice, but to re-emphasize the work of the manager in advancing clinical practice on the unit with their patients.
Well, that's an innovation right there. Is can we now in this crazy time innovate and take away the non-nursing things that we have been put on us because people were cutting their budget or people thought nursing will do it? Can we back
Right.
out of some of those things, not compromising our relationship with patients? And that's an innovation that everyone should be thinking of right now in this nursing shortage. Everyone should be thinking about how do we reshuffle so that we can keep our true nursing core, but still not have all these extraneous things that got put on our place because we said we would do it all, right?
Right. We can be responsible for everything.
Yeah.
So Marie and Julie, you know, there's awesome thread, lots of support for a lot of the comments that you're making. You guys are actually kind of weaving in, you know, some aspects of the conversation we were hoping to get into tonight. You know, you're talking about nurses leading this change. Thinking about Marie's comment in her introduction about how when she introduced primary care nursing and that model of nursing, Marie, you said that people, you know, people didn't respect the work that you were leading, right? They thought that this was an out of the box idea, that they didn't see how it applied to nursing. How did you, you know, we're talking about nursing, how did you overcome that?
There
How
were
did
two
you win
groups.
people over?
There were two groups. There were two different types of responses, basically. Those who were positive and those who were negative. The people who were negative were people who had a perception of, how do I want to say this, that the role of the primary nurse belongs to a much higher level person, to a much higher level person than a staff nurse. That this should be the role of a clinical specialist, that this should be the role of, and to my way of thinking, a nurse has a license to make decisions about the nursing care of the patients that are in their charge. And that was the whole definition of primary nursing, is that the nurse makes decisions about the nursing care of the patients who are. And so I couldn't see that objection to it had validity in the real world. And I'm very operationally minded. I have my feet firmly planted on the ground. So when we're moving into other areas other than direct patient care, I just tended to leave them to their own discussion. I never really tried to argue with people, but I didn't agree if I didn't agree. What I had, and I know this was a very special situation that most people don't have. In fact, I never did have it again after that time. But in those years, the hospital administration at the University of Minnesota hospitals had a philosophy of management that supported decentralized decision-making. They wanted to empower people in their hospital. So they gave department heads a lot of authority that they hadn't had before, and so on. And they really, really liked what we were doing with the empowerment of the staff nurse. They really felt that the whole direction of primary nursing was exactly what it needed to be. Educators, absolutely not. I didn't understand then why. I understand now that they were going through throes of painful curriculum development that created enormous problems later on in the 70s for the University of Minnesota School of Nursing. At the time, I felt that they were just giving us the cold shoulder, which they were. We had a nurse on the committee, on the planning committee of primary nursing, an educator, relatively high up in the hierarchy. She said nothing all the way through. She never had a comment to make during the meetings. When we asked her to participate in that all-day seminar by outlining the curriculum implications, potential for primary nursing, she refused. So the educational component of that seminar was extremely weak. I'm not going to explain just how weak it was. And so we had a lot of support from staff nurses. The real thrust of the movement into primary nursing came from nurses and a few administrators. Some of you, some of you may recognize the names of Joyce Clifford and June Warner. She was one of the earliest proponents, and these earlier proponents really got very enthusiastic about it. They welcomed visitors to come. So there was a movement going on where my role was to go with the flow, to go where there was positivity. And basically, I learned very early in my time as a change agent to not pay too much attention to resistance. I think too often we try to get 100% acceptance of a new idea before we implement it. And what we end up doing is spending a lot of time fighting resistance, which only makes it stronger. I learned that if I ignore resistance, in fact, my tip to myself was, imagine yourself as a flood of water rushing down a hospital corridor, where there's an open door, you rush in, where there's a wall, you rush on. When you need to come back and deal with the wall, the water rushing by the wall, you will have to create enough energy and enough support that the wall is beginning to crumble by itself. So oftentimes it was that kind of strategy. And I didn't read that in a book. It was just common sense for me that if I'm going to sit here and try to convince these naysayers that this is what they should do, I'm going to waste a lot of time. We have all these people ready to go over here. Let's have a consensus-based decision-making process and go. Oriana, is this what you're looking for? Or have I gotten us off track?
No, right. I think this is, how do we bring about change, right? This is a great discussion. And when you think about, and both of you have touched on the events, over the past 2 years, with the pandemic, racial inequality, social division, how do you think this, so I'm going to ask both of you a multi-part question. How do you think this has impacted the profession, the culture of nursing? How has this changed the work of nurses? Is there, can these events, what is that silver lining? How can these events be used for good, for the profession and for healthcare?
Well, so Ori, I wanted to say a little something in regards to what Marie mentioned about naysayers, because this applies to where we are right now with innovation, because there's a lot of blockades and self-imposed policies and procedures that we've put up around us. And I would say you can be water and do that, yes. But what I always say is, I will just love you through it.
Yeah.
Because, right? Because
right.
people are afraid. And right now we have a chance, and I see it in the chat, for people to do tests of change. I saw something in the chat about someone said, why can't we use scribes? I'm like, yeah, try it. Get on a unit and try it. And you heard this is the same esprit de corps that Marie uses. Try something. Just say, it doesn't have to be a new policy or a process. It doesn't have to be just, can I try it a week and can I measure it? We're all scientists. We can do that. I think in this current environment, with everything that has happened, the pandemic, misinformation, polarization of our own profession over vaccines. I mean, let's be real. This has been polarizing. Grief, trauma. Someone in the chat said we have PTSD and trauma and grief. Yes, this is our reality and where we are. But can we use this time to say this is our time?
Right.
And nursing has made history. And yes, we are tired, but I've seen nurses who are very tired and burned out do some pretty crazy things because their hearts are that big. Mm-hmm. And so how do we lift each other up and say, let's just try some things and let's not look at the barriers, the walls crumbling down? And I know that sounds, like it's almost easy, like, oh, that's just, but really that's how all change happens, right. Is that organic? I know how to do it. I'm not going to get the whole hospital to let me use a scribe, but can I get someone to let me try a scribe on one shift, one thing? And then as people talk about it, well, that might work. Yeah. And I actually think that, Marie and I haven't got to spend a lot of time with you since I left school, but the way we innovate, though I work on organizational disruption and you do, the Marie Manthe thing, we really have a very similar approach,
Yeah,
which is I'll love you through it. I'm going to try it, and I'm going to just try it and let it organically happen. And then when it's working, people will
right,
be like, well, yeah, we should have done that.
right,
And can we do that now? Because people
right.
aren't really paying attention to us now. They're worried about shortage. They're worried about different things. Do we just slip that change in
That's
there and
right.
then go, oh,
Yeah,
that might have
voila.
worked.
Right.
It doesn't have to be big and systemic. I mean, I do love a system disruption, but maybe that's not where we're at right now. Maybe this is just the little picky changes that we just say, I'm just going to try this, and I'm not too tired to try it. I'm not too tired to have a solution.
It's the butterfly wing in the forest
So true.
now. And I really think that new science and old science, we really need to move into generative leadership. That's another whole topic, but I really want to get into that at some point in time. But the other thing I want to say, and to me it's important to say this, and that is that we need to think for ourselves. I have read lots of work published by lots of very bright people. And there was a time in my life when I thought that I should accept everything that was written about nursing. They were written by wiser people than I. And so I was, for more than half, no, not, about a third of my life, I was really a very obedient Catholic. And I just thought, wiser people have done this, and therefore I need to be able to accept it, even if it doesn't make sense to me. And at some point along the way, that changed for me. And I think the most important thing we all can do now, I'm talking about the kind of change that Julie has so well defined. The real change that starts in real practice can be done by thinking through for yourself what makes sense. Having some trusted colleagues whose judgment you admire and trust, working with you, batting ideas around about how to make something happen. And so it is in that thinking through for self that I think we don't give ourselves enough credit. And we have a lot of common sense, and we have great experience, and we need to be able to let our brains be creative and figure out how to deal with a specific situation. I think that think is one of the most important qualities we need to develop with ourselves and to be able to rely on. I know for me that most of what I've been talking about has been stuff that I realized I was going in a different direction than the literature was saying, but it made sense. So I
And I
think
think
that
listening too. I'm
that's
going
me
to
too.
challenge everyone on this entire podcast that if somebody comes to you with some kind of an idea, listen and say, "Let's try it."
Yeah,
Because I think sometimes we're our own worst enemy. And if you're a nurse leader on this call, my best days as the CXO is when a nurse calls me on Sunday on her way to work, and this happens, and says, "I want to do a pay it forward reward and recognition program." I'm like, I'm on it. Let's do it. What are you thinking? I people text me and say, I don't understand this. I want to try this. I've seen it. And if you're doing it with them and you're having power with them and you're just giving them the vessel and the encouragement, but I think sometimes we're our own worst enemies because we say, oh, that's a policy. Like we didn't write those policies ourselves. Come on now. So how do we support each other? So
yeah.
can any of you just support some crazy idea that someone mentioned and just say, let's try that, let's beta test it, let's do something? And I think that will lift us up too, because it is really a hard time right now, but innovating and change with love and not making you stress can be empowering. It can be fantastic.
I remember being shocked when the CEO that I was working with at the U at that time told me that his policy was to say yes anytime somebody came to him with an idea. He said, I always say yes first, even if I don't think it's going to work, because it might. And furthermore, you can always say no later on when you get more information and more experience. And I've kept that in my heart, and I've watched leaders. I've watched that specific issue. Do you say yes first, or do you say no first? Show me. it has a profound effect on how much energy and activity goes into whatever the problem is that needs to be solved. Yeah, Julie, I want to work with you.
We always say that every time we get together. We say that all the time.
Well, and so much of what you guys are talking about in conversations in the thread, people, saying yes, and, being open to willing to try new things. We have a clinical specialist who has been commenting in the chat and talking about evidence-based practice. And one of the things about innovation is that innovation tends to happen before there's research, right? It's a very, it's a very early stage of work, and it starts with that beta. It starts with that trial. It starts with that test of change. And once something works, right, then we start putting the data to it. We start collecting the evidence to build the research. And so just recognizing that these innovations, the ability to say yes, allows us to create new evidence and to create, best practice moving forward. What advice would you, both of you have, as you're thinking about the shape of the profession moving forward? You're thinking about, where, when you look at the work that nurses are leading, what's your hope for the profession moving forward? What are some of those things that are standing out to you as opportunities and different tests of change that you're seeing work across the country?
You want to go, Julie?
Sure, I can go. So what I would say to all of us is don't, just like Marie said, don't be too tired and don't be too worried about what other people think as you're in your innovation space. That sounds trite, but it really is a great mindset. My worry is that we're too tired to take the hill now. However, what I really want to impart is that nursing, if we're not at the table now, and if we're too tired, and there are new models of care being developed, they'll be developed around us, and they'll parse out our beautiful holistic care, and that worries me daily. So we have to rise up to be able to say, if you're at a hospital and they're thinking of doing something, some new model of care, we've got to be in there. And so what that means is that y'all have to take really good care of yourselves, and you got to guard your empathy. And if you're burned out, you have to acknowledge it, and you have to agree to do the care that you need. I'm tired of the self-care thing. It sounds selfish, but can you care for yourself so that you can care for our profession?
Right.
And I think that might have been, something we rolled our eyes about, but right now it's vital to innovation. And if nursing can't innovate, with colleagues, but not be at the table, then I'm worried about our future. So our future means we take great care of ourselves, we heal ourselves so that we're driving the innovation, and nursing is creating its own future, not letting other people parse out our work. And I'm hearing this, and it makes, Marie and I have talked about this, it makes me very crazy when I hear someone say, we're going to do this on a unit. And I'm like, is nursing think that was a good idea? Stop. So that's my worry, and that's my cautionary tale, but also permission to take really good care of yourselves.
Yeah,
really,
absolutely. Yeah, we have responsibility for ourselves. That's the first responsibility we have in life. And it's one that oftentimes we let go to the background. So I'm beginning to think about self-love, and it's an odd term, and it makes me feel a little bit icky because it sounds like narcissism, and I don't mean that at all. But we really need to honor the fact that we were born, we've been created for a purpose, and to make sure that we're moving in the direction that we can handle that purpose. Julie, I've been thinking of something altogether different. When we talk about being at the table, I'm so tired of that term. I'm so tired of what's wrong with the practice. And so I think, what could we do? What could the profession do? The thing that the only thing I come up with that sounds to me like it's practical and might work if we were clever and intentional and smart is to demand or to request or to require an opportunity to get to know members of the board. It seems to me that until we get an opportunity to garner some board support, and I know that to the CEO, this is absolute heresy, that we would have access to their boss. But when there needs to be a way that we have an opportunity to interact with the members of the board so that they hear from us what the issues are and what we need for this institution. Now, I know it's a little pie in the sky and a little bit unrealistic, but when I think about this issue of seat at the table, it's not going to happen when we go there with our hat in our hand and say, please, may I?
Well, and I think that you have a seat at the table if you're in the suite, right? So again, I'm going to really encourage people. There are people on this call that would make fantastic COOs. There are
Yeah,
people on this call
right.
that would make fantastic CAOs of ambulatory services. We have
Yeah.
a VP, a PhD prepared VP, Dan Drake, shout out to Dan, that runs our clinical practice, and that's brilliant. So when you have nursing in
Yeah.
those C positions, they already have access to the board. I mean, when I think about when I took my job as a CXO, not a CNO, I'm a CXO, and I decided I wanted an experience committee that dealt with team member engagement and patient experience. They just don't have those for boards. But since I'm in this role and I'm a chief, then that's what we're going to have.
Yeah.
So if
Yeah.
if we don't feel like we're being heard, then if we're in those leadership positions, and
That's
I
right.
think all leadership positions need a nursing brain right now.
Yeah.
If so, take your chances, take your shot.
Right.
You'd make a great COO, you'd make a good director in a clinic, you'd make a great HR advocate. There's so many things that we could do, that we don't have to be confined to clinical practice, to take our clinical
That's
brain
right. That's
into
right.
the places where they need to be, and
That's
then
right.
you are at the board, right?
Yeah. That's
And
right.
I actually think that relationships with nursing, with other non-clinical people, are very valuable. You
Yeah.
could mentor your CEO, you could mentor the director of food service and EVS, you can mentor and be friends instead of alienating, be friends with support services, other directors, help them. Nursing is deeply skilled in many, many areas of strategy. So
That's right.
that's kind of, I think we
I'm
should,
with
I think
you.
we should just take over, just
I do
go for
too. Yeah.
any leadership job. I think we can do it. I think we can do it.
There is a group called the Coalition for Nurses on Boards. It's a national organization that is dedicated to helping nurses prepare themselves to be able to interact or function as members of boards. And
Yeah,
it's just another
that's great.
step in your direction. I think you're absolutely right about that.
Yep.
Yeah.
Yep. I think about, in my career, I've been a CAO, a COO, a CNE, a CXO. I've kind of made my way in the C-suite, and I was always a nurse.
Yeah. Yeah.
I was always a nurse. Every role I take, I have a nurse's brain. So
You see,
I think that's a call out right now, I think.
that's where I've seen a difference in certain people. I've seen people who have moved into maybe academia or into high-level administration because they don't like nursing. They're nurses, but they've had an unsuccessful nursing start. And so that situation, I think, is fraught with danger.
Yeah, that's fraught with, that's worrisome.
Yeah,
That's
it
kind
is.
of,
I know.
yeah,
I know.
that's worrisome. So
So, Julie, thinking about, one of the articles that you wrote and the work that you're leading within your organization, what are some of the innovations that you brought about within your organization as a leader during this period of time? And would love for you to tell the audience about, share with them your article, What's Love Got to Do with It? I'd love for you to do both.
So we published an article that actually was the keynote for the World Nurse Congress this week, called "What's Love Got to Do with It?" And that's a tough word. It makes you feel a certain way, like Marie said. But when you're bringing operationalizing love at the highest levels of an organization, it is going to be disruptive in a good way. And so a lot of the things that we innovated during the pandemic was for well-being for nurses. So we knew that nurses needed, and all clinicians, we're very generous, all clinicians, anyone really needed help. So we put in tranquility rooms. And again, this is about innovation and evolution. So we put in tranquility rooms in all of our hospitals and all of our big clinics where the nurses could go. They had individual stations, they had gratitude journals, different writing, funny movies. I saw someone mention that, landscapes to watch. But then we found out some of the nurses, and massage chairs. We put massage chairs in all of them. Then we found out some of the nurses couldn't leave their units. Don't be discouraged. We then moved the tranquility rooms up onto the units, so the ICU nurses could just walk into a tranquility room. We did well-being pop-ups. I would say I'm as proud of this as anything. Is nurses aren't good at taking care of themselves, and they're certainly not going to call EAP. So we did these well-being pop-ups where we made these spa kits, and they look like a spa kit. They've got different wellness tips in them, but they had those cool things you put in the refrigerator to help your eyes for your mask. And we'd say, hey, you can have these great spa kits. Come on in and chat with us. And then we actually had our medical director, who's integrative medicine doc, and our EAP just kind of ask the nurses, how are you sleeping? How's it going? And we had a lot of referrals from there when we came to them. We also had a lot of chocolate. That's how we got them to come to the rooms. We did listening circles where people could come to listen. I would say similar, Marie, to what I learned from you from salons, is we'd open up a listening circle. We did an open mic. We set up a room that just had nothing in it but a mic and some instructions, and said, you want to tell your stories? You need to get them out. We set up an open mic room. We do a lot with journaling. We also do gratitude. We have a gratitude focused salon where we help people think about gratitude as a venue for well-being. We did the mindful meditations. A lot of the innovations that we did were directed at helping people get through the pandemic, because we knew that if our clinical team was not resilient, we were not going to make it through. And then the other thing that I have to say, Ori, is when you're setting strategy for an organization, our foundational strategy, our foundational metric by which all other metrics hinge from, is team engagement. And so you ask anyone and they say, what's your foundational metrics? Team engagement, because everything comes out of that. You can't have good patient experience, you can't have good clinical outcomes unless you have great, engaged, well cared for workforce. So once you have that at the organizational strategic level and you've set the goals, things can kind of fall into place. So you're probably thinking, how could you do all those well-being things? Well, if we're talking about team engagement as our core metric, we have to have it. And so I think through the pandemic, we did a lot with just things to help people weather this pandemic, which we are seeing isn't really stopping. And yes, thank you, Eileen. A sense of humor helps, and and we made sure that we had funny movies in our tranquility rooms, because sometimes people just needed a laugh. And chocolate, yes.
So Marie, when you're thinking about the work that, looking forward, what area of healthcare are you starting to focus in at this point in time?
When I think about where is the healthcare system going after this, if it survives, which I still think is an open question, I think that home care is going to be have a much more prominent place in the overall healthcare system. At least I hope so, because from the humanistic point of view, having stronger home care opportunities with important and strong nursing control and input, I think might be the direction that we're going to want to go. At least, again, I hope so. Institutionalizing, medicalizing every single problem is not smart for the future. And that's what we tend to do. So, and when I say that, in my own mind, I see the profession taking a hold of home care as a life life-saving, life-giving component of citizen experience. So I don't know how many of you are familiar with that program called Birdsong. It's a home care system, and I think it's Norway, where they have an absolutely phenomenal capacity. The RNs are actually doing the assessment of the people who live in that community to make sure that they are staying out of long-term care facilities for as long as possible. It's a really powerful nursing role, highly respected throughout the system. And somehow nursing has made it that way in that country. And in this country, home care still has not got the kind of within the profession respect that it needs to have in order to assume that important role in the future. So I know it's not the most popular thing, the ICUs are still, but nevertheless, for the future, I think home care is our place. In terms of the acute care system, I have some radical thoughts about staffing levels and staffing ratios that I know a lot of people don't understand or won't agree with. One of them is that every RN who's got a year or two of experience really should have a tech assistant, a technically trained assistant who works with that RN, same shift, same schedule, same holidays, same days off, where they become a partnership working together. We've innovated with that. I have some research that we did, I shouldn't call it research, data collection about the impact it has on people's morale, on the amount of workload they can handle. And it's an absolutely phenomenal concept that we haven't bothered to find out how to operationalize on more than a couple of units at a time. I think we're going to be inundated with what you were talking about, Julie, where they're going to take bits and pieces of nursing and farm it out to people in order to relieve us, but it actually reduces our role. I think that we should own the totality of nursing practice and that we can have work groups that include lesser prepared people working under the supervision of the RN. And we need to be so careful to understand that we're not talking about team nursing, which is a care delivery system, but we're talking about relationships within a unit of high quality teamwork amongst established groups of people of different levels of skill. We have so many opportunities to utilize all of our resources in a much wiser way. And again, I think a lot of what needs to happen is we need to get out of our own way. We need to stop holding on to some old myths and take a fresh look at that role of the professional nurse and the kind of support she needs in order to do the job that she has, and which includes making sure that all the patients in there that are being cared for by the group are getting high quality care. So aides need to be brought back into the nursing role. To have aides working separate from RNs without communicating, and this happens so many places, it's just unbelievable. There's no communication between the member of the staff who touches the patient's skin and sees the patient's body and the person who's making clinical nursing judgments. It's appalling. So I think we need to rethink some of the things that we got from the industrial engineers who were re-engineering nursing 20 years ago. We're stuck with some of their beliefs, which have nothing to do with the organization of a professional practice. Wow, there you go.
So some of the comments that are coming up in the chat, talking about the role of education, right? And how do we incorporate innovation into education? And Marie, it actually makes me think about a conversation that we had. And would you be willing to share the story of how nursing prepared, and some of the nurse cadet story that you shared with me, and how education shifted to meet the need of the country?
Yeah, it's so funny, and yet it's not, and yet it gets a message across really, really well. So you all may know that at the University of Minnesota, we have a program called the MN, the Master in Nursing, which is a post-baccalaureate 16-month program that's pretty highly intensively clinical, since the prerequisites have already been taken care of and these people already have a bachelor's degree. So it's a pretty intensive program, especially in the beginning semester. And this was when the COVID shutdown, total shutdown occurred. School was shut, doors were locked, and we had these new budding nurses coming along, needing clinical practice, and the skills labs were shut. So I don't know what the faculty said. I'm going to tell you what a student told me, that they are encouraged to figure out how to demonstrate that they know the basic nursing skills by creating an opportunity to deliver that skill within the framework of their home and the kind of equipment and supplies and so on that they have at home, and that they could demonstrate that by having a video camera taken, a video made of the experience. So this woman, okay, so the task was to demonstrate that she knew how to do a female catheterization. And she did. I said, what did you use, for Pete's sake? And she said, well, I used that tall Kleenex box. And she said, I took the cover off, that round thing on top, you take that cover off, and then you see there's two pieces of plastic that cover the Kleenexes, and that could appear to be similar to labia. So she used the appropriate cleansing technique on the Kleenex box, and then she inserted the catheter just to the amount that it needed to go in order to hit the bladder on the average woman, and demonstrated in that way that she understood the principles of female catheterization. And that was videotaped, and it passed. And she's a very creative woman. She's going to make a crackerjack nurse. And I absolutely love that story. Talk about innovativeness, talk about creativity. I mean, she had all the principles. She had every principle nailed in the demonstration project. So that's it. That's what you wanted, isn't it, Ariana?
Well, I think it's a great example of right, how nurses innovate, and they to meet the need, right? And thinking about the story that you shared, just how education models prepared nurses to meet the need of our country during the World War, how that really was the foundation, changing the education model to help move nurses through the system to be able to meet the needs of the nation. And with the increasing cost of healthcare, right? We had a wonderful policy innovation and advocacy forum in September, and Liz Fowler, who is one of the leaders for the CMS Center for Innovation, she talked about, and she doubled down on it in a few different ways, talking about the role of nursing leading innovation in healthcare moving forward, and the importance of the profession, and that this is, the importance of nursing in this moment. And so my question to both of you, just to wrap up, recognizing that we're coming close to time, is why nursing, right? Why now? And I also want to open it up to the audience. Based on today's discussion, what will you continue to do or start doing? Maybe stop. How will you start promoting innovation within your workplace? What did you appreciate about the discussion? And how did this information influence your thinking or feeling about the topic, or any questions for the speakers? But while you guys are putting those questions or thoughts in the chat, that. Looping back to Marie and to Julie, why nursing? Why now?
Wow. So why nursing is because we have stayed very true to how we solve problems. We are holistic thinkers. We take care of the whole patient. We have the whole, we understand pieces of a whole, right? And so healthcare moving forward, what's going on is not going to be solved in a vertical or in a silo, and we've never worked in one. So that's why nursing, and why now is never waste a good crisis. As this crisis has crippled healthcare, really, and us, don't waste it. Don't waste it. If somebody will let you try something, try it. If there's a nursing shortage and people are worried, then think of new methods that you can staff and take care of your inpatient unit or your clinic. Think of ways that you can still keep patients safe, because that's the other thing. Why nursing, why now is we're probably, I don't want to say the only, but we are a profession that cares for our patients. And when in times like these, with the social determinants of health and everything that's going on, we won't, in our innovations, we won't leave the patients out of it. We'll solve for them too, and for us. And that makes us perfect for redesigning our future.
Yeah, I agree with everything you said, Julie, and want to put a slant on it too, that first of all, I want to say I became a nurse because a nurse colored in my coloring book when I was 5 years old. And she transferred something into me. So I've had an inspirational experience that has driven my focus on nurse-patient relationships. So within the framework of that drive, I see our role today in society in very much the same way some of our historical great legends did. People saw us even many years ago as the opportunity, as the profession having the best opportunity to advance social justice as any other entity within the country. And I see today that we have an instinctive focus on sort of non-materialistic truths. And we have a capacity of looking at the world from a very holistic, and the people that we take care of from a very holistic perspective, which is mind, body, spirit. And many times in the salons, without any guidance at all or any movement, we end up talking about those deep connections with human beings that we have because of the role we have, because of our connection with the vulnerable people. So I think this is an important antidote to some of the excessive greed, the excessive materialism, the excessive reliance on numbers over judgment that the system continues to move towards. I think we have a special place. I really do. I really and truly do believe we have a special role to have in balancing some of the excesses of society. But we have to keep our focus true. We have to keep our values intact. And we have to be constantly willing to think things through for ourselves based on fundamental truths and ancient historic values. We all need to understand the values upon which the profession professes to. Yeah.
And be ever mindful of our own mental health.
Yeah, right.
We owe it to the world to take care of ourselves.
That's
so
right.
that we can take care of this planet and take care of the humans on this planet, but we have to take care of ourselves.
And the first step and the practical step about that is accepting the fact that you have choices to make about the way you think, the way you act, and the way you feel. No one can make you feel bad without your consent. No one can make you do something without your consent. So learning how to exercise choice and accept consequences will take all of us out of the victim role that sometimes feels very familiar in nursing.
Perfect. Well, again, lots of support in the comments and the threads from all of those in attendance. And I want to say thank you to both of you. We have been so fortunate to have your vision, your breadth of experience tonight, and to hear how you're leading change, how you have led change, and your hopes for the profession.